And diastole is relaxation of the ventricles. All right, but we will use often the term systole and diastole when we talk about things happening in the artery as well. So where the pulse is occurring, we still refer to it as a systolic and diastolic phase. All right, but generally, we're talking about the heart when we talk about the term systole and diastole. So what you're looking at is what's called a pressure wave. All right, we have the systolic pressure and we have the diastolic pressure. So when we're talking about the blood pressure that we measure, the higher number is the systolic number, the lower number is the diastolic number. All right. There's this little thing here called the dichrotic notch. So see how we have it goes up, comes down, there's a little blip, right? That little blip is called the dichrotic notch. This is a slight increase in pressure that occurs as a result of the closure of the aortic valve. So in the vessels, systolic pressure is kind of determined by aortic compliance and then the cardiac output. All right, so how much blood is being put out by the heart and how well the aorta stretches. So I'm going to notice here, and I'll give you guys a formula in a minute, but mean arterial pressure is not the mean between the systolic and diastolic, and there's a reason for that. So there's a different way to calculate mean arterial pressure. We'll talk about that. The difference between systolic and diastolic is a figure we call pulse pressure. All right, so if we subtract systolic from diastolic, that gives us what we call the pulse pressure. And that's a somewhat useful measurement. So it typically in a healthy individual stays roughly the same. So as we age, both our systolic and diastolic blood pressures go up, but they typically go up about evenly. So our pulse pressure remains fairly constant. Any questions so far? All right, so diastolic pressure is affected in part by what's called the total peripheral resistance. We mentioned this before. So this is essentially how much resistance is on the arterial side of things. So remember, we have our capillary sphincters that can be closed or it can be basically constricted or dilated, and that will influence peripheral resistance. So that influences essentially how much blood can get back to the heart, how much blood is in the venous system, and that influences our diastolic blood pressure. And then both types of blood pressure are basically affected by our volume. Right? So if we're low volume, we're going to tend to have a lower blood pressure. If we have what's called high volume or volume overloaded, that tends to go along with high blood pressure. All right, so what we see as the pressure wave is actually a kind of combination of multiple things going on. So there's what's called the basically pressure waves. Right? So when we look at our blood pressure in the arm, we're actually not just recording the blood pressure as the blood is going out this way, we're also recording a pressure wave that's coming back up towards the heart. So the first wave is what we call the incident wave. The second wave is what's called a reflected wave. And if you know any physics, you may be familiar with the concepts of something being either in phase or out of phase. What's that mean? If something's in phase, what do we say about it? For waves.
I feel like they're in sync.
They're in sync, yeah. So if two waves are in phase, what do they do to each other? They amplify each other. All right, and then if two waves are directly out of phase with each other, they do what? They cancel each other out. All right, so these waves, the reflected wave and the incident wave, are not quite in phase with each other. Right? So they're not out of phase, they're not fully in phase, right? Kind of in between. So there's a bit of augmentation that goes on. All right, that's what they're showing here, what they call this augmentation pressure. So if I flip back to this wave you see here, right, is actually a combination wave. So it's both our incident wave and our augmented wave put together. So when we do those traces, that's what we're seeing. So what is this showing? This is showing that as we get older, all right, our augmentation is actually pretty high, all right, versus if you look at a younger person, notice that there's more augmentation out here in the radial side than there is the aorta. So here's the aorta, here's the radial artery. So what happens, so in a younger individual, oops, I might have a little fun here. In a younger individual, as we move down the aorta, all right, our wave is getting bigger. So our systolic blood pressure actually is higher out on our radial artery or our femoral artery than it is at our aorta because of this pressure wave augmentation. So if I were to do a central line and put a pressure transducer in the aorta, the systolic pressure that I would get is higher than, or sorry, is lower than the pressure that I would get in the brachial artery or the radial artery or the femoral artery. Okay, so thought question: if blood pressure, so if pressure indicates how things flow, right? High to low pressure. How can I have a higher pressure here when blood is flowing down? Dum, dum, dum.
Is it because it gets the material gets smaller?
Nope.
Or get clogged? Or
That would actually make it harder, wouldn't it? If it's smaller.
I was thinking like come from larger, getting smaller, it will get more pressures.
But it's pressure's high pressure to low pressure is the way direction flows, right? So why wouldn't blood flow back to the heart then? It's a semi-trick question. Have I tricked everybody? Yep.
Gravity?
Not gravity. Any ideas? All right, so what type of pressure do you think is determining how blood flows? Is it going to be our systolic pressure, or is it going to be our mean arterial pressure? It's going to be the mean. All right, so the mean arterial pressure is not like I said, it's not arithmetic mean, so it's not the difference, so not in between our systolic and diastolic pressure. If you do your mean arterial pressure, even though our systolic is higher up here, the mean arterial pressure is dropping. All right, so that's what's kind of determining it. It's not the highest pressure or the lowest pressure, it's the mean pressure. So a little bit of a trick question there. Why is this important? So basically what's kind of happening for a younger person, all right, we have this forward wave and then we have the reflected wave. So we're most in phase further out. All right, so basically the reflection is wherever there's kind of a branch point of the aorta, all right, there's going to be some amount of pressure wave reflected backwards. Okay, so think about the blood is flowing through, it's hitting the walls, that's causing a reflected wave to go backwards. All right, so we have a forward wave and a reflected wave. So the nearer the end of the aorta, we are mostly in phase. As we move the reflected wave back up towards the aorta, we get what's called dampening. All right, so remember the aorta is kind of, it is tough, but it is also somewhat flexible, right? So it has the ability to kind of expand and contract, sort of. So the more compliant it is, the more dampening you get. So that by the time you get back to the aorta, there's not much of this augmentation going on anymore. All right, so the augmentation's pretty much gone away at this point. This is kind of a good thing. So what winds up happening is that in a younger individual, this reflected wave is coming back while the aortic valve is closed. So it's not causing any sort of issue with blood coming out of the heart. That makes sense? So we're not fighting against that reflected wave. Getting old sucks, all right? Our vessels get stiffer. Note that the wave stays pretty much the same height all the way through for someone who is 68. So the stiffer walls means that that reflection goes back easier, right? It's not being kind of muffled by the sponginess or springiness of the aorta, right? The aorta is stiffer, so that wave travels back with more fidelity. You get more augmentation. So this actually makes the work of the heart harder as we get older. So don't get old, it stinks. Just don't do it. All right, and then they're showing a 54-year-old here to kind of show you something in between. So we've got some augmentation still going on, all right, but you can see it's, the augmentation is spreading further back, not quite all the way back to the aorta. All right, questions? All right, so I jumped forward to the slide, but so there's a number of things that can kind of affect the shape of this wave. All right, both the reflected and the forward wave. All right, and one of the biggies is that peripheral resistance of the arterioles. So we'll talk about that a little bit later. Any questions so far? All right, so we're doing more physics, I promise. It's going to be so much fun. All right, simple math. Before we get to the physics stuff, we'll do some simple math. So mean arterial pressure, all right, two different ways to calculate it. All right, the reason it is not a full mean is because the time points for systolic and diastolic phases in the heart are not the same. So we spend about 2/3 of a cardiac cycle in diastole. So that means that it weighs more in the calculation of our mean arterial pressure. All right, so that's another reason why this, systolic being higher in the branch arteries is not going to result in a higher mean arterial pressure because diastolic is having a greater impact. All right, and doesn't matter which formula you use; they both give you the same answers. Okay, the one on the right, for whatever reason, physicians seem to like this one. All right, it has note here, here's pulse pressure. So it's basically 1/3 the pulse pressure plus the diastolic blood pressure. For me, it's easy to remember the whole 2/3 in diastole thing, so I just do this one. So systolic blood pressure plus 2 times diastolic, divide the whole thing by 3. Any questions? Yes, you'll be expected to calculate a mean arterial pressure on the next exam. All right, and just a couple of examples to show you, you wind up with the same thing. So 140/80 gets me a mean arterial pressure of 100. Okay, so mentioned before, the elasticity of the large arteries is what allows that pulsatile flow to be propagated. All right, so take a look. Here we are, we're in the heart, and then we're heading out into the arteries. So you have this pulsatility in the arteries. Notice way bigger pressure differences in the heart itself. All right, then we have the arteries. We get smaller and smaller arteries, that pulsatility starts to drop off. We get into the arterioles, and we're basically not having pulsatile flow anymore. All right, so now we're just going to have non-pulsatile flow until we get back to the heart and the pulmonary arteries. A couple of reasons for that. One, we see increased vessel resistance. All right, we're getting narrower vessels. And then remember that we're seeing a decreased pressure for a couple of reasons. One, we have increased cross-sectional area. And then just, of course, we're using up that energy, that pressure energy in order to propel the fluid forward. Any questions? right, so pulse pressure can be a very useful feature. So this is with patients that have heart failure, and basically what this study kind of shows is that the pulse pressure was a very good predictor for cardiovascular death, cardiovascular disease death. And this is specifically in heart failure patients, right? So this is not, pulse pressure is not going to be a predictor of cardiovascular death in someone without heart failure. But basically what they kind of showed was that it was a very good indicator, right? There's our p-value less than 0.001, and then sensitivity and specificity. So sensitivity basically means how well can a test detect something, right? So we're showing 83% sensitivity, which is pretty good. And then specificity is how accurate is it towards the thing that we're looking at. Right, so we talked before about the pregnancy test. That has both a very high sensitivity and a high specificity. Okay, so that's a very, very good test. So when we're talking about physical parameters, not many things are very high on sensitivity or specificity. So this is actually a pretty good indicator. They're showing you some other ones. Any idea how would you measure the ejection fraction out of the left ventricle? How would you measure how much blood is coming out of the ventricle? A couple different ways you could do it. Any ideas?
EKG?
EKG will not give you volumes.
Oh.
All right, EKGs do what? What do they show you? Electrical activity of the heart. So how would I get a volume? Why is it a Monday? Should I bring coffee for everyone next time? Yeah. Come on, someone must have an idea. How do we measure volume in a system? Well, blood draw, I mean, we'll get a specific volume out, right? That's not going to tell us how much is coming out of the heart.
Something with pressure?
We could. So yeah, we could calculate it based off of pressure potentially. What else? How would you actually physically measure the volume coming out of the heart? What's that?
Echo.
What's an echo?
I don't remember.
Do you remember?
No.
Can anybody tell me what's an echo? What's an echocardiogram or echocardiogram? It uses ultrasound. Yeah, so it's using ultrasound, so what does it do then? What's that? It can measure the speed of the fluid pass through. Does it give us a picture? Oh yeah, yeah, so it gives a picture. We visualize it, right? So we can use an ultrasound in order to get the left ventricular ejection fraction. So that's a non-invasive way. If we wanted to get a really accurate measure, we could actually put a catheter into the heart and basically measure the flow as it goes past. Yep.
If you use an angiogram, is that also the same imaging?
Angiogram won't necessarily give you the volume, although you could calculate it. It'll give you the area of the chambers at different times and give you the area of the coronary vessels. They don't typically calculate volume with it, but you could potentially. So.
If you put the catheter in, how long does it stay?
However long you need it to stay in, I guess. So, I mean, it's not, typically you're not going to do that. So that's an invasive procedure. You're not typically going to put a catheter in person for that. And usually if they put a catheter in, they're actually more interested in pressures than they are the volume. But you can actually put a flow meter in there. And so experimentally, you'll read experimental papers that talk about basically doing that, having a flow transducer, and they basically measure the flow over periods of time. And, they'll show you that. The flow going up and down during systole and diastole, and how consistent it is across time, that sort of thing. So, but yeah, that's a more invasive way of doing it. So echo is really easy. All right, you don't have to put anything in the person. How do we get this one? How do you get pulse pressure? What two figures did I say you needed? Systolic and diastolic blood pressure. So how do we get that? Yeah, blood pressure. Yeah, just put cuff around them. Usually the arm, could be a leg, could be an ankle, could be a wrist. All right, but that's it. Simple blood pressure cuff. Right? So really simple, non-invasive, easy thing to do, easy to measure, easy to keep track of. So for heart failure, turns out pulse pressure is a nice, very convenient, very easy, non-invasive way in which you can measure essentially a patient's progress in their disease. And you can have them take their pressure at home, for instance, and keep a diary so you can keep track of it over time. So, all right. Any questions so far? So we've kind of talked about systole and diastole. We've talked about what blood pressure kind of is. All right, some of the things that kind of affect blood pressure. Now we're going to talk about blood, how it moves through the system. All right, so hemodynamics. So it's a subset of fluid dynamics. All right, and many of the principles we're going to talk about are consistent with those are derived from principles involving gas or water flow. All right, if you know anything about fluid dynamics, you'll know that there are a lot of assumptions made in the models that they're used. So that kind of limits the applicability to organisms. All right, so we got to have things like Newtonian fluids and frictionless surfaces and all these other things in the assumptions. So those things aren't in real life. Why do we care? Why do we use this stuff then? Just so that us professors have something to test you all on, right?
Maybe it's like a baseline or like comparison.
Yeah, it's something we can use for comparison. It's something we can get some baseline data on. So it's an approximation. So it's a good way to kind of get a rough idea of some of the things that are going on, with the understanding and the caveat that a lot of the models we use to describe and the formulas we use to describe these things, they break down when we look at them more specifically in real life, all right? Because blood is not a Newtonian fluid. Our vessel walls are not stiff and rigid and frictionless. So there are a number of things that don't fit the model perfectly, but it's still useful as a predictor. It's still useful to determine kind of how properties work and understand them a bit better. Okay, so what's velocity? So anyone who's had physics, what's velocity?
How fast you can move?
Fast, how fast something moves?
Yeah.
All right, so what would be like a mathematical way of describing that?
Over time.
Distance over time. Dating myself here, this would be a comic that stopped being published before most of you were born,
Calvin.
called Calvin and Hobbes. Named after two philosophers, actually. So, but yeah, so Calvin wishes the speedometer to know how fast they're going. Hobbes basically says, yeah, we could do this. Sounds like math, and now I stop caring. All right, so velocity is how fast a particle is moving. How is that different from flow? What is flow? Anybody know? They tell you to go with a flow. What are they talking about?
Movement of a substance over time.
So movement of a substance over time, how are we measuring that substance? Volume, that's what I was looking for. Good, so volume over time. So velocity is the distance, and I'm using the term particle on purpose. So like the distance that a particle moves over time. Flow is how much a volume moves over time, right? So if we're looking at blood, if we talk about blood velocity, I might look at an individual red blood cell and how it moves. If I talk about flow, I'm talking about how much blood, right, 10 mils, 100 mils, is moving over a distance in time. So the two often get used interchangeably. They are not, and I will admit I get lazy sometimes, and I do sometimes use the two terms interchangeably when I should not. I try hard not to, but it will occasionally happen. So if I do it, just be aware. We're mostly going to focus in on flow. All right, because we're not as concerned about the velocity that the blood is going. We're more concerned about the flow. How much of it is moving through the system over a given time. All right. And what do you think about flow and blood? Do you think it is constant? Do you think it changes? Is there a third option I'm not thinking of? No. What do you think? Changes. All right, how many people think change? Okay, how many people think constant? Oh, no one. Oh, jeez. I thought I'd get somebody. The answer is it depends. So again, another trick question. I love asking you guys trick questions. So if we look at the body as a whole, flow tends to be relatively constant, right? So your heart beats relatively similar throughout the day. I mean, obviously there's variation. It goes up, goes down if you're standing, walking, sitting, those sorts of things. All right, but generally we're putting out similar amounts of blood every heartbeat, unless our activity level changes. So typically our flow as a whole is pretty constant. But if we look at individual, say, organ systems, our flow will tend to vary, right? So if I've just eaten a big meal, the blood flow to my digestive system is going to be increased, while blood flow to other areas might be decreased. If I go out and exercise, then my blood flow to my skeletal muscles may now be increased, and my blood flow to other areas may be decreased. So, and this is going to be true of a lot of the things that we talk about as far as these hemodynamics goes. Perspective is extremely important. So we need to know what we're talking about and what we're comparing. Are we talking about the system as a whole, or are we talking about parts of the system? All right, pressure. I think we have talked about this before, right? What would be a good definition of pressure?
Force exerting on an object? Or?
Force exerted on an object. So when we talk about blood, what's the major force that exerts the pressure?
Oh, what was the question?
What's the force that exerts the pressure in as far as the blood goes? What's that?
The heart.
The heart's going to be part of it. All right, so the contraction of the heart's going to help us generate the pressure. The heart's not contracting in the arteries, right? So how do we have pressure in the arteries? How do we have pressure in our veins?
Cardiac muscle, skeletal muscle.
The elasticity? Okay, good. So then what's causing the pressure? In the arteries, that's true. That's going to be part of it. But what? So like I'm in a vein. Say I'm in a vein. So there's no pulsatility. It is lower pressure, but there's pressure there. What is causing the pressure?
Is it skeletal muscle?
Nope. What's that? The blood itself.
Oh.
Right? So the blood itself is what's pushing out against the vessel walls. So that's what's generating the pressure. We call that hydrostatic pressure. All right, so hydrostatic pressure is the pressure of the fluid against the vessel wall. Okay, so hydrostatic pressure is going to be very important. As was mentioned, yes, the heart is going to generate a lot of that driving pressure, that initial pressure that kind of gets everything going. All right, the elasticity of the arteries, their ability to snap back, that contributes to that pressure as well. But obviously, by the time we get down into the arterioles and the venules and the veins, we kind of lost that. We don't have the pulsatility anymore. So our pressure is purely the hydrostatic pressure. Not the way to take your blood pressure. Okay. So you can take your pulse from the carotid. I would not try to take the blood pressure. Okay. Resistance. What is that when we use that term resistance? I've already used it a few times. What is resistance?
Opposite force.
Hmm? If you know anything about electronics, you might know that might have a good definition for this.
Like reduce.
Reduce what?
like a resistor, so it reduced the, I guess, the pressures. By going the
Kind of.
opposite?
Kind of. It's gonna reduce some pressure a little bit. Yeah. What's majorly impacted then?
The another force that go in opposite
So
direction.
if I have a higher resistance, what's that gonna do to the blood? Slow the flow, right? So that's resistance is essentially the force that is opposing flow. So in electronics, a resistor is something that impedes the flow of electricity. Right, so something that has high resistance doesn't allow electricity through, something with low resistance lets it through. Right, so a metal wire has low resistance. The rubber coating around the wire has high resistance. Right, another fun picture. All right, no cartoons this time, sorry. All right, so this is showing you guys various different types of shapes. All right, and so you might be familiar with this more kind of like from air fluid dynamics, right? So the concept of an aerofoil, all right, but we can also use the term hydrofoil. All right, so this looks like what? What does that look like to you guys, maybe? A teardrop, all right, I like it, a teardrop, all right, I'm trying to think physical object. It's something we'd see in nature or engineering, like a fish, like what type, okay, good, so that looks kind of like a fish, right? So if this is water, if it's going around the fish, what does that mean? Is there a lot of resistance for the fish swimming through the water? No, its shape helps to reduce the resistance. Does that make sense? So you've got a fluid moving across a shape, all right, and here there's very little disturbance of the water, right? So the fluid, I should say, the fluid. So our object can move through the fluid and not cause a lot of disruptions. Up here, if we've got like a square, we have all these what are called vortices. See all the kind of like swirling around behind it? All right, so the energy of movement gets disrupted by the object, all right? So there's, in other words, more resistance. All right, so think about an airplane's wing is shaped like this, not like that. All right, and that's kind of why. So it helps to reduce the resistance. And we'll talk a little bit about what are some things in the cardiovascular system that either help or kind of hinder resistance. All right, another electrical term. Anybody know what a capacitor is? Remember way back I talked about the venous system being a capacitive system. No electrons, people. What's that?
Does a capacitor hold the charge?
It holds the charge, yes, exactly. So in electricity, capacitors hold charge. So when we talk about capacitance, we're talking about the ability to store energy. And in our case, we're talking mostly about our ability to store blood. So the venous system has a high capacitance. The arterial system has a low capacitance, right, on our systemic side. So our ability to store blood is referred to as capacitance. The arterial side is sometimes referred to as the resistant side. All right, so that's where the majority of resistance in the cardiovascular system is. It's also the part of the cardiovascular system where we can alter resistance. All right, so we can directly change resistance of the system, and we do it predominantly on the arterial side of things. All right, so arterial side is a resistant side. The venous side we refer to as being the capacitance side because it's where we store our reservoir of blood.
Can you explain how the arterial side is the resistant side? Because wouldn't it normally just float like it doesn't push against gravity like the venous side? Like that seems more like the
Right, and this kind of goes with the fact that it's a high pressure system, and that's part of it. So we're going to get to it, and it's going to have to deal with arterials, and we will definitely talk about it. So I'm just kind of setting it up for right now. But yeah, we're going to talk about how can we alter resistance, and what does that do to pressure and flow? Because these three are going to be the really important ones. So flow, pressure, resistance are going to be our three really important properties. All right, more physics. All right, for this one, I'm not going to expect you to know the formula. Just kind of understand the principle behind it. All right, so this is something called Laplace's law, or the Young-Laplace equation, or Young-Laplace modulus. Basically, this explains why a capillary does not rupture. Okay, and I should have gotten some balloons. I usually do this as a demo. Maybe I'll try and remember and do it for Wednesday. But basically, if you take like one of those long balloons that you can do the balloon animals out of, whatever. All right, so imagine you fill that up, right? If I take a pin and I puncture the balloon, what's going to happen?
The pressure is gonna flow on.
It's going to burst, right? So it depends though. If I hit the balloon where the wall is the widest, it is definitely going to rupture. But think about those balloons, how they're kind of like, it's really hard to get air all the way to the end of them. So you have this little like point at the end that does not fill up with air, right? It's just too hard to get it filled. You take a pin to that area, it does not rupture the balloon, right? Air will start to hiss out of it for sure, but the balloon won't rupture because it has less what we call wall tension associated with it because of the smaller radius. All right, so if we get to a small radius, our wall tension tends to be fairly low. All right, so does that make sense? So what vessel is going to have the highest wall tension, do you think? You've had anatomy, so I know you can give me some names. What's that? The aorta. Why the aorta? Because it's the biggest diameter, right? So it's the biggest diameter and is also giving the highest pressure, right? So the vena cava has a large diameter too, but the pressure of the blood in it is much lower, right? So the wall tension is lower. But the aorta is a good example. So we have a high wall tension. Why does the aorta not rupture like a burst balloon?
Elasticities.
What's that?
The elastic fibers.
There's elastic fibers surrounding it, right? And what else is surrounding it? I heard it, what? Tissues, like what type of tissues? So we have elastic fibers and then also what other things?
Collagen.
Collagen, what else? Smooth muscle, there's a biggie, right? Big muscular wall. So those things are what help to resist that wall tension, right? So even though we have a very high wall tension, we have materials that are helping to prevent rupture from occurring. Now, rupture can occur. We call that an aortic dissection or an aortic aneurysm, depending on what type of thing is happening. Those are really bad when they happen, all right? But typically they don't happen. Now we get down to a capillary, we do not have elastic fibers. We do not have vascular smooth muscle, right? We have a single layer of endothelial tissue. So this is why we don't have capillaries rupturing all the time in our bodies, because that would be pretty bad. Right? It would be pretty wasteful. We'd have to be repairing them all the time. It would not be very efficient. All right, so they are a very low pressure system, right? So the pressure on the capillaries is pretty low, but the radii are so low that there's not a lot of wall tension on them. Okay, following? Okay, so that's kind of how Laplace's law applies to the cardiovascular system. Right, this is why capillaries do not rupture. It also helps explain why our bigger, thicker vessels are kind of made the way they are. Why we have this, thick tunica surrounding that blood vessel, because there's a lot of wall tension and we're preventing it from rupturing the vessel. questions? Yeah.
So, just to recap, basically you said the reason why the smaller vessel doesn't rupture is because of the wall tensions is so much less?
Yes, because we have a very small radius.
Okay, so volume, the radius is determining.
The radius is kind of the determining factor. So,
Okay.
sorry, the formula is kind of shown there. So for a cylinder, it's pressure times radius divided by 2.
Okay.
And for a sphere, oh wait, I think that is the sphere. Did I have that wrong? Yes, I have, sorry. That's the one for a sphere. For a cylinder, it's just P times R. So yeah, ignore that. That's for a sphere, not a cylinder. So for a cylinder, it's T equals P times R. So radius gets smaller, tension gets smaller.
Yes.
All right, so again, the capillaries can withstand increased flow or pressure without bursting, so that's good. So we wouldn't want to open up those capillary sphincters and then bust all those capillaries by putting blood through. Okay, velocity and flow. So velocity, now remember that's movement of a particle, is inversely proportional to the cross-sectional area of a tube, while flow is directly proportional to both the velocity and the area. Or in math terms, V equals Q over A. So Q, don't ask me why they chose Q for flow, but that's what they use for flow. Alright, so Q equals flow. Lowercase v is for velocity. The big A is for air, is for cross-sectional area. So if I keep my flow constant, if I have a greater cross-sectional area, what happens to my velocity? If this is a really big number, what happens to velocity?
Smaller.
It goes down, right? Does that make sense? So if I look at capillaries and then I look at the aorta, what do you think as far as velocity goes? Which one has the higher velocity? The aorta, right? Because it does not have as much of a cross-sectional area as the capillaries do. We're talking all the capillaries. I'm not talking individual capillary. We're talking the whole system of capillaries. All right, so if we look at the whole system of capillaries, we have relatively lower velocity because there's so many of them. Right? So even though they're tiny radius, tiny vessels, there's just so much of them. There's such a large surface area. They have a very low velocity. Does that make sense? Oh wait, like I said it backwards. Yeah, the smaller the area, sorry, so ignore what that says there, because I'm talking, let me rephrase. If we look at individual vessel to individual vessel, smaller vessels will have a greater velocity. So we're looking at not as a whole. Does that make sense? So if you're looking at an individual capillary compared to an individual artery, the flow is faster in the smaller vessel. So we're looking at them side by side. If I look at them as whole units, it's not the same. Yep.
Aren't both statements true?
Yes.
So if you're looking at one capillary,
Right.
then its velocity is going to be faster. But
Correct.
if you're looking at the system of capillaries, because it's a greater surface area, the velocity is still lower.
Yes. That's what I was trying to get across. I was like, because the way I have it phrased there sounds the opposite of what I just said, and it's because I didn't specify that I'm talking about individual vessel versus the whole system. All right, is flow constant? We already talked about this one. Again, it's a dependent statement. So in the whole system, usually flow tends to be fairly constant. However, there's going to be areas in which flow is going to change based off of kind of our status. Like, so are we active? Are we resting? Are we asleep? Are we stand upright? Are we lying down? Are there parts of the cardiovascular system, do you think, where the flow is essentially constant no matter what we do?
It's the brain.
What's that?
What was the question? Like
So
where?
is there any areas, any like organ systems or parts of the body where flow is going to be pretty much constant?
Is it the brain?
Hopefully should be. What's that?
Brain.
The brain. Why the brain?
Well, you don't want high pressures or changing pressures up there.
Right. We don't want changing pressures. We don't want less flow for various reasons. Now, that being said, like when we sleep, there is a bit less flow because we're metabolically less active. But for the most part, no matter what sort of kind of activity we do, our blood flow to the brain tends to be pretty constant. So there's a system that kind of keeps the pressure relatively the same. So even if our systemic pressure increases, like say we're exercising, so our blood pressure goes up, the pressure in our brain stays about the same, right? It doesn't really change. Likewise, if our blood pressure drops, we will do what we can to maintain pressure in our brain. Right? So what happens if we don't maintain the pressure in our brain? You pass out. Yes, that's called syncope when you pass out. There's a type of it that's related to your position called orthostatic hypotension. So in other words, if you stand up too fast, you can pass out. But we have, like I said, mechanisms that try to keep that pressure constant. So most of the time you all stand up, you don't pass out. At least I hope so, right? Like I hope nobody passes out every time they stand up. That would be bad. Okay. Please do not even attempt to memorize this formula. Okay? I don't want you to memorize this. I always consider taking this out anyways because it just causes confusion. Basically, Bernoulli's principle tells us the effect of velocity on pressure and the effect of gravity on pressure. Now for us, since we're not, 2 stories tall, gravity is not going to have a big impact. Right? Now if you're looking at water towers, all right, that's where the Bernoulli's principle, and we talk about gravity, that's where that kind of becomes important. How high is the water tower off of the ground has an impact on how well things flow from that tower. So for us, our height is so minimal that gravity is not really having an effect. The amount of gravity at your feet versus the amount of gravity at your head are pretty similar to each other. So we're mostly interested in what's happening with respect to velocity and pressure. So on the right here is kind of a simplified version of the formula. All right, this little row here is the density of the liquid. All right, so we have velocity, we have pressure, we have density, and something called the Bernoulli constant. This is not a universal constant. It applies to the specific system, so you actually would have to calculate it for whatever system we're looking at. What is the whole point of this? All right, according to Bernoulli's principle, if we've got a rigid tube, velocity is inversely related to the cross-sectional area. So as the tube gets wider, velocity would decrease and pressure would increase. So greater volume of fluid means we have greater pressure. Again, this is an ideal liquid in a rigid tube. This does not happen with blood flow. All right, because this would say that if I went from my big artery to a smaller artery, right, what should happen to the velocity?
It increase, right?
It should increase. That doesn't happen in the cardiovascular system. Okay? So about the only time you see Bernoulli's principle in action in the cardiovascular system is when you have an irregularity in a blood vessel. So say you have an atherosclerotic plaque or a thrombus. And do we of course do not have any dry erase markers in here, do we? Oh, there we go. All right. Yay. All right. So if I have my blood vessel, all right, I've got blood flowing through it. If I have, say, a bump in the vessel from a plaque, a thrombus, something, all right, in the area around here, the velocity is actually going to increase, right? Because how much volume, say I've got 10 mils here, all right, I have 10 mils here, I need to get 10 mils out in the same amount of time over here. This is a narrower space, right? So I need to get that same volume through a smaller opening, so it has to move quicker through that one spot where it's narrowed out. Does that make sense? So that is where Bernoulli's principle kind of works in cardiovascular system, is if we talk about like a small obstruction. So just in that localized area, you're going to see that increase in velocity. When we actually look at blood vessels, when we go from the arteries to the veins, they slow down as we go from the larger to the smaller vessels. And then picks back up again. So the venous system, it does kind of fit more, because when we get to the venous system, as the vessels widen out, we do see a bit of an increase in velocity. All right, so this one you are gonna need to know. All right, so we have something called Poiseuille's law, getting closer to reality. All right, Q is flow. R refers to the radius. So PI minus PO is the pressure gradient from the inlet side to the outlet side. Oftentimes you'll just see it written as delta P. All right, so the change in pressure. The thing that looks like an N is the Greek letter eta. All right, this stands for viscosity. And then L stands for the length of the tube. So you're going to see why this doesn't quite fit our cardiovascular system. Assumptions that underlie this law: non-pulsatile flow, a Newtonian fluid, meaning it's homogeneous and has constant viscosity, the presence of rigid cylindrical tubes, and what's called laminar or smooth flow. So you remember back to the different shapes that I showed y'all. The one that looked like a foil, all right, looked like fish, that had smooth flow all around it. The one that had the box had turbulent flow, right? It had all those vortices. So non-pulsatile flow, well, that doesn't work for the arterial side, although most of our circulatory system is non-pulsatile, so that's kind of close. Blood is most definitely not a Newtonian fluid. I'll talk about some of the cool things about blood later. Blood vessels should not be rigid cylindrical tubes, right? The more rigid they get, the more problems you tend to have. But that one is true, it's laminar smooth flow. So we do mostly have laminar flow. Any idea what causes turbulent flow? Where would we see turbulent flow naturally? What's that? If there's a blockage, definitely. All right, so if there's some sort of blockage, like that said, that clot or the or atherosclerotic plaque. What about healthy, normal turbulence? Any ideas? What would interrupt the flow? Yep. Changes in pressure. Yeah, we're not going to see very large changes in pressure, but in the early portion of the heart, we do. So that does tend to promote more turbulent flow. It's like on the level of the aorta. All right. Oh no, atmospheric pressure is not going to really impact us. So, at least I hope not. I mean, if we have a huge change in atmospheric pressure, that could be really bad. We don't typically experience huge swings in atmospheric pressure. How do you mean?
Since we're talking about the square and how it causes turbulence, I was thinking like the brain, since there's a blockage, would really cause turbulence, like the parts of it isn't good.
Okay, so blood-brain barrier refers to the tightness of the endothelial cells. So the blood's going to flow through just fine. It's not getting into the brain, but that's not going to cause turbulence.
Is it when the artery bifurcate?
Yeah, why would that cause turbulence?
Because, well, it's splitting, so.
It's splitting.
Yeah.
Right, so we don't have a straight pathway. So anytime the pathway bends, you're going to have a tendency for turbulent flow. There are a lot of bends in the circulatory system, right? We were not designed to be hydrodynamically efficient. We are not a very good design. And if you've taken anatomy, if you've taken embryology, it's because we came from fish. So we have a great circulatory system if we were fish. We do not have a good circulatory system otherwise. I can tell you why that is later. It's not part of this course. All right. So what are the important things? What do we care about this map? All right. It tells us a couple of very important things. One, flow is directly proportional to the axial pressure difference. Right? So the difference in pressure from one side of the system to the next is what determines flow. So the greater the pressure differential, the greater the flow. So if I want to increase flow, I can increase my pressure. This one is also really important. Flow is directly proportional to the fourth power of the vessel radius. So if I increase my resistance, increase my radius, sorry, I'm jumping ahead. If I increase my radius, I increase my flow by a power of 4. So if I double my radius, my flow goes up 16 times, right? 2 to the power of 4. This is less important, right? Flow is inversely proportional to the length of the vessel and the viscosity of the fluid. All right, we're not really going to worry about that too much because you're not changing the length of your blood vessels, at least not in any sort of normal time frame we would consider when we're looking at blood flow. And viscosity, we'll talk about viscosity a little bit later, but again, we're not going to worry about it too much. Flow velocity is going to be greatest in the center of the vessel and lowest where it interfaces with the vessel. So why is that? What force is that we refer to? Why is the blood that's in contact with the vessel wall moving slower than the blood in the center of the vessel?
Resistance.
Resistance? Yeah, what type of resistance? Friction. It's friction, right? So it's just frictional force. So that is going to be very important. And we'll talk a little bit about that when we talk about the microcirculation and what happens to viscosity and flow. All right, so this system fits best with the arterioles, the capillaries, the venules, and the veins because they do not have that pulsatile flow. All right, so it's less applicable to our arterial flow. We still talk about it. Okay. So part of this term, right, so the pi R4 8 eta L is called something called the proportionality constant. And it's the reciprocal of resistance. So I'm going to do a little algebra with this a little bit later, but just kind of remember this is going to relate to resistance. All right, so I kind of already gave this away. So Bernoulli was Swiss, Poisson was French. So French beat out the Swiss as far as hemodynamics go. So typically velocity in the blood vessel is going to increase with our increasing diameter. How to explain this? We're going to use a German. All right. Anybody recognize that last name from any reason? Anything?
Ohm's force.
Ohm what?
Laws.
Ohm's law. All right, good. Yay! What is Ohm's law?
Electricity resistance for
What is it?
something resistant.
Something with resistance. Something resistance.
Multimeter.
Anybody? All right. V equals IR. V is voltage. I is current. R is resistance. And again, I have no idea why they chose I for current, just like I don't know why they chose Q for flow, but here we are. All right, fun little cartoon, kind of shows you the idea. All right, so voltage is what's pushing the current along. All right, amperage is the units we use to measure current. So amp represents the current moving through, and up here we have our resistance, which is in units called ohms, named after ohm, and this is what's preventing or restricting flow of the current. All right, so that nice little cartoon demonstrating those ideas. So here's a circuit kind of showing the same things. We have our voltage, current passes through our wire, a resistor will help impede current flow. We can rearrange that formula. All right, so V equals IR is the same algebraically as R equals V over I. All right, voltage is difference in potential between 2 points. Current is the flow of the electrons along our conductor, and resistance is that material force that opposes the flow of the current. Any thoughts how this might apply to blood flow? All right, well, this is how we do it. So our fluid values, our fluid dynamics, our hemodynamics, are analogous to those electrical circuits. All right, so pressure is the difference or the gradient between two reference points. That's basically the same idea as voltage, right? So the electrical potential difference is voltage. This is our pressure differential. Same idea. Flow, the velocity of our fluid and the volume of that fluid moving through the system, is the same idea as the current. And resistance is pretty much just resistance. All right. So properties of the vessels are what's going to determine resistance. So radius is going to be a biggie. We're going to talk about that. The degree of branching is something else we'll talk about. And then just the physical properties themselves, right? So like the material that makes up the lining of the inside of the vessel, that endothelial layer. All right, that's going to have an impact on how much resistance there is. And so these are all basically variations on Ohm's law. So here's my V equals IR. Well, V equals RI, actually. I should rewrite that. So change in pressure equals Q times R. If I'm looking at resistance, resistance is the change in pressure over flow. If I'm looking at it from the perspective of flow, flow is the change in pressure over the resistance. You all following so far? All right, and I said before, when we talked about Poisson's law, pi r4 over 8 eta L is the reciprocal of resistance. I'm going to show you guys now how do we get that. All right, so here we go again. There's Poisson's equation right there. Pi r4 equals delta P over 8 eta L. This was one of the formulas I gave you, the Ohm's law formula, right? R equals delta P over Q. I'm going to take this whole thing and put it where the Q is, right? So since Q is in my denominator, what do I need to do with this? I need to flip it, right? So my 8 eta L is going to be up here with my delta P. My pi over 4 pi minus PO goes down here on the bottom. Now remember what I said, pi minus PO does the same thing as delta P. Right, it's just a different way of writing out the same term. So delta P and this pressure in the inlet minus pressure in the outlet, those are both delta P's. So I can cancel those out. And that gives me this 8 eta L over pi R4 equal to resistance. You following? So that's why I said the pi R4 over 8 eta L is the reciprocal of resistance. So to get the reciprocal, I would flip this, right? So flip that, pi R4 over 8 eta L equals the reciprocal there. So why is that important? Oh, sorry. So why is that important? Right there. That R to the fourth. What does this tell me about resistance and the radius of the vessel? Are they directly related or inversely related?
Inverse.
They're inverse, right? Because this is on the denominator side. So a larger radius means what in terms of resistance? Lower. That make sense? So the smaller the radius, the higher the resistance. The important part here is the power of 4 relationship. So if I reduce the diameter by half, how much do I increase the resistance?
Reduced by half.
16, right? 2 to the 4 gives us 16, right? So if it's 1/2, that 2 to the 4 means it's going to be 16 times more resistant. Does that make sense? Yeah.
You said if you reduce the diameter by 1/2.
Or radius. I mean, diameter is twice the radius, so I should have said reduce the radius by 1/2, but it's same principle. All right, so if I'm reducing the radius by 1/2, then it's going to increase the resistance by 16 times. So small changes in the vessel radius can have huge impacts on the resistance. So which blood vessels do you think, on the arterial side of things, we talked about different types, which ones do you think have the greatest ability to change resistance of the system? Large vessels or small vessels? Can we change the radius of the aorta by very much? No. Can we change the radius of an arterial? Oh yeah. All right, so the smaller size vessels, the arterioles, allow us to really change our resistance by a great amount, because we're working with a small radius to begin with, so we can make, comparatively, right, to the size of that vessel, very large changes. We could make it twice as wide, or we can make it twice as narrow. We following? Right, so the resistance is related to the radius. Again, it's by a power of 4. All right, we'll come back to this again. All right, any questions to this point? Actually, this is a good spot to take a break. We did a bunch of math. Let's take 5 minutes. And remind me to turn my recorder back on when we get started again. Otherwise, I'll forget.